This is Dr. Gaffari, Jessica Gaffari from CTA Pathology, and today we have made it to the end of lever. So in and of itself, that's cause for celebration. So today we will be covering lever chapter 36, cutaneous metastases. And these are not commonly encountered, but when you do encounter them, it's important to know how to work them up with immunohistochemistry. So just some background, about 4% of malignancies will have cutaneous metastases, and the clues to diagnosis can be the location in the dermis, patient history, cytologic atypia, ectopic tissue or tissue that doesn't belong, a lack of connection to the epidermis, presence within a vessel or a lymphatic, but really the most important thing here is clinical history. So hopefully, usually as you're a clinician, you're going to have some sort of suspicion, although sometimes patients can present with metastatic disease prior to having a diagnosis of a known malignancy. So most commonly, more common cancers are going to present with metastases and usually in locations close to where they originated, but in some instances that may not be the case, and we'll cover that here in a little bit. But of cutaneous metastases, about 60% are adenocarcinoma, with lung, GI, and breast being most common, and usually breast or lung, depending on whether you're studying men or women, will be more common. We also tend to see squamous cell carcinomas in the oral cavity, esophagus, or lung, and also in immunosuppressed patients, including transplant patients. And then other metastases that we do tend to encounter with relative frequency are melanoma, sarcoma, Merkel cell, so other tumors to be aware of. But we are going to start off today with an example of a metastatic lesion. And here I think you can get some hints that at low power, the process is in the dermis, and we have a proliferation of atypical cells within a little lumen here. So these look like they're within lymphatics, and there's an associated host response here. There are some areas that look like maybe they're vaguely forming a gland, so a little circular structure here with some secretions, but quite pleomorphic. So compared to the size of a lymphocyte, these cells are very large with variably sized nuclei. Here you can see a mitotic figure, and these tumor islands are really plugging up all of the lymphatics here. So this is an example of intralymphatic spread. So before we go and get a lot of immunostains, history is very helpful. So this is from the chest of an older woman with a history of breast cancer. So in that case, we can kind of limit our workup and be a little bit more specific. Here is another little example of a ductual or some glandular formation. So typically when we are working up an adenocarcinoma, we will start for breast with a cytokeratin 7, and that will normally be positive in breast cancer. If there's a known history of breast cancer, we may not start with those stains though. So for the purposes of staging and prognosis, it's important to know the hormone status of these tumors. So if patients haven't had a workup within the last year, usually we'll check ER, PR, and HER2/neu. The breast tumors are usually also positive for gross cystic disease fluid protein, although that's a little more old school. EMA and CEA, though those are not specific for breast cancer, those will label other adenocarcinomas. So typically, like I said, we'll see pleomorphism, atypia, mitoses, glandular formation. A bottom heavy infiltrate is another clue to a metastasis, though we don't really see that here. This is intravascular, which is another pattern that we typically see with breast cancer. Something else that we typically see with breast cancer is Indian filing or nests and cords of tumor. Here you can see a little bit more down here in the dermis that there's some tumor within a vessel. This one doesn't really have much of that Indian filing, but typically what you'll see are epithelial cells similar to what you're viewing here, but cords tracking between collagen bundles. There may only be very limited suggestion of ductal differentiation, but you may be able to find some signet ring cells. And again, the site on the body and the age of the patient can be helpful clues to diagnosis. But if you're not sure if it's epithelial or perhaps lymphoma, which can also sometimes show Indian filing, then immunohistochemistry can be helpful. Typically with those dermal tumors, there's also a background of fibrosis. Now, if you had a dermal tumor or something that had this glandular differentiation and you weren't sure if perhaps this was eccrine or a primary epidermal or primary adnexal tumor, which sometimes you can also see on the chest, then a P63 or P40 can be helpful. So P63 and P40 are both positive in primary epidermal derived tumors and should be negative in breast cancer or other metastatic lesions. And a cytokeratin 5/6 is helpful. And then if the patient had no history of a primary carcinoma or adenocarcinoma, you could also add a CK7 and CK20 to your cocktail. So in general, CK7 will be positive for tumors above the diaphragm, where CK20 tends to be positive for tumors below the diaphragm. There are some exceptions to that rule though. And in our histologic differential diagnosis, you might think of acute myelogenous leukemia. If there were maybe more of a dense dermal infiltrate of these atypical cells, sometimes they can have some overlap and look lymphoid, but those would be positive for LCA or leukocyte common antigen, myeloperoxidase, and have slightly different cytologic characters. And then primary adnexal tumors like syringoid eccrine carcinoma would be positive for P63. And then if you're near the oral cavity or the upper head and neck, you might think of a metastatic salivary gland tumor. And those label positive with CK7 and androgen receptor and would be negative for ER and PR. So those can be some helpful tips when you're trying to sort out the primary origin of the tumor. One more important thing I want to mention before we move on for breast cancer is GATA3, GATA3, and that's a newer marker that is usually positive in breast neoplasms, also in some bladder cancers, but GATA3 is something that they might ask you about on your boards. So moving on in the category of adenocarcinomas, here we have an ulcerated nodule, and you can see at low power, there's somewhat adenoid or cribriform architecture, and still relatively well differentiated. But when we go up in higher power, you can see that this is recreating some tubulovillous structures, and there is some pink secretory material here with a few neutrophils in the lumen. And in this case, we have a metastatic colon adenocarcinoma, where the metastasis is typically seen in the areas of the abdomen or the perianal area, usually well differentiated, and you may see some mucin, like you can see here. You may see signet rings cells, and the glandular elements in the dermis can have these neutrophilic abscesses in the lumina. These are typically going to be cytokeratin 20 positive. So again, below the diaphragm, CK20 positive. Another newer marker is CDX2, and these will be villi positive. So think of villi and these little projections, and villi will stain these. Here's some nice example of that secretory material. So sometimes you'll see these periumbilical or on the abdomen, but usually a poor prognostic indicator for these patients. In the differential diagnosis for this tumor, you may consider metastatic pancreatic carcinoma, much less common than colon, where the glands show more of an irregular architecture. And I can show you an example of that. Let me just show you one to compare and contrast. Here we have an example of metastatic pancreatic carcinoma, and you can see that there are some similarities to the metastatic carcinoma from the colon. Here, the glandular structures are small and maybe embedded in more of a fibrotic stroma, and they don't have that same tubulovillous arrangement that we saw in the colonic lesion. There's somewhat of a edematous myxoid fibrous stroma, and these relatively well differentiated islands of tumor here with some signet cells and creating these little glandular tubular structures. Here we don't see quite as much of that neutrophilic debris within the lumina. And these will stain with CEA and also CK7. So in contrast to colon cancer, which is CK20 positive, pancreas is usually CK7 positive, and will also label with cytokeratin 19 and CA 19.9. So that's something that you follow in the blood as well. And immunostaining is positive here as well. Moving on to our next metastatic lesion, from low power, you can see that we're in a hair-bearing area with mature terminal follicles, so large kind of normal size follicles. We have a very nice excision here, and this is typical of this site of this metastasis. From low power, I think you can also appreciate that there's quite a bit of hemorrhage. So this is a bloody and kind of clear cell lesion that is typically seen as a metastasis in the head or neck. And moving in a little closer, the individual cells have a somewhat trabecular architecture. So they're forming these little lines of cells associated with this delicate vascular stroma. And again, prominent hemorrhage. As we come in higher, you can see that this is pretty well differentiated. So there's not a lot of nuclear pleomorphism or atypia here. You may see some low-grade atypia. But here, I think you would consider your clear cell tumor differential diagnosis. And the main thing to differentiate this tumor from would be a clear cell hydranoma. Since we're in the chapter of metastases, this is an example of renal cell carcinoma where metastatic lesions are common to the head and neck. And this is a clear cell adenocarcinoma. So you can see that there's this abundant vacuolated cytoplasm. And unlike sebocytes, where you tend to have indentation of the nucleus, here you can see that the nuclei retain their nice round shape. They're not being indented by that cytoplasmic material. These typically label positively with PAX8, PAX8, and they are also RCC positive and CD10 positive. Important to note, these are CK7 and CK20 negative, and they are often positive with EMA and CEA. They may also be Vimentin positive. From low power, if you notice the hemorrhage here and the vascularity, you may consider a pyogenic granuloma, and clinically, sometimes they can look like a pyogenic granuloma, especially if they're ulcerated, but a biopsy should help you to differentiate that. So this doesn't have the typical lobular architecture that a PG would have. Again, prominent small nucleoli, and your clear cell differential diagnosis may consist of a sebaceous tumor, which we talked about the nuclei here, an adnexal neoplasm like a clear cell hydranoma, a clear cell squame or basal. Usually there would be some more typical areas of squamous or basaloid differentiation and maybe something involving the epidermis, a balloon cell melanoma or balloon cell nevus, a xanthoma, but not quite right for that, and maybe a benign vascular tumor. So I just want to show you one, kind of our most important differential here. So here we have kind of a nice compare and contrast. This lesion is also a biopsy from this scalp. And here you can see that there's a well-circumscribed tumor surrounded by this capsule of fibrosis. So slightly different architecture than what we saw with a renal cell carcinoma, which was like a cannonball. And that's typical for what you'll see in some metastases. So this one here is, again, more well circumscribed. And when we zoom in, you can see that the architecture is slightly different. So while we do have these clear cells that really do resemble the clear cells that we saw in the renal cell, there's also areas where we have more eosinophilic cells, and then some areas where we're getting little gland formation. So toward the center here, the cells are lining up kind of around these clear structures and forming little ductules. And those are lined in some areas here we go, lined in some areas with this columnar epithelium with projections into the cystic lumina. So we have these little kind of protrusions of cells into these little lumina. And then we also have these areas of peripheral darker staining cells. And in some areas, you may be able to appreciate an outer layer of myoepithelial cells surrounding some of these structures. So the architecture is somewhat different. Here again, you can see some of these little protrusions and gland formation. You may see also some decapitation secretion, but immunohistochemistry can be helpful in the differential diagnosis here. So this would be RCC negative, CD10 negative, PAX8 negative, if you were concerned about a clear cell hydranoma versus a renal cell carcinoma. Because again, there is a bit of histologic overlap, but typically you're not going to see these nice, well-developed lumina with the decapitation secretion in a renal cell carcinoma. And then clear cell melanoma, you could get an S100, and that will be negative in renal cell carcinoma, but positive in a melanoma. All right, now we are moving out of the category of adenocarcinomas and into squamous proliferation. So here you can see that we have a hyperkeratotic epidermis with an adjacent ulceration and a very dense dermal proliferation here that essentially shows evidence of keratinization. So we have keratin pearls and then squamous epithelium, some neutrophils here, dyskeratotic cells, and the degree of cytologic atypia here is quite striking. So there's nuclear pleomorphism and hyperchromasia. And again, here you can appreciate some foci of keratinization. So this is an example of a metastatic squamous cell carcinoma, and it's helpful to note that there is no connection to the overlying epidermis. So this is abutting the epidermis, but it is not arising from the epidermis. And these will be positive for P63. The other name for that is P40. You may sometimes see cytokeratin 7 positivity, but that's more the exception than the rule. And some of the markers that we can use additionally for squamous lesions include cytokeratin AE1, AE3, which is a high molecular weight cytokeratin, or CAM 5.2, which is a low molecular weight cytokeratin. And there are also pan-keratin cocktails, cytokeratin 5 and 6. So as we're seeing here, you may see focal keratinization with necrosis. You can see some squamous pearls. In contrast, adenocarcinomas tend not to stain with high molecular weight cytokeratins. So sometimes with an adenocarcinoma, you may see some areas that resemble keratinization or a tumor that may not be as well differentiated. So you can see in these areas here where it's just very dark and highly atypical. If you had a biopsy just showing this portion of the tumor without these areas that were keratinizing, then your differential diagnosis might be a bit more broad and you might do more of a workup. But sometimes as these tumors become less well differentiated in a metastasis, they may not label well because as they are not visually well differentiated, their immunohistochemistry may become less well differentiated. So sometimes they'll lose some of the markers, but typically a pancytokeratin is a good way to start. But if you were to start seeing some little gland formation or maybe hallucinating some little ductules here, you might wonder if this was an adenocarcinoma. So that's definitely in your differential diagnosis, maybe right here. So if you just had this part of the tumor without the other parts, then you might want to include a CEA, an EMA to see if is this an adenocarcinoma, and then a cytokeratin 7 and 20, because those would be positive in maybe a lung cancer that has metastasized or colorectal cancer. But here, seeing the lesion in whole, there's really nice squamous differentiation. I should say in general, before we start ordering a lot of immunohistochemistry for any of these, especially if it's a poorly differentiated tumor, your most important tool in your toolbox is the telephone or connectivity to the electronic medical record to review the patient's history. So history is really important, and you can, in general, narrow down your workup pretty significantly or not even do much more of a workup at all, depending on the clinical history and the scenario for a given case. Next is a relatively more common tumor that we encounter in clinical practice. And here you can see that there is a well-circumscribed nodular proliferation in both the upper and the lower dermis with no connection to the overlying epidermis. So that's one of our clues for a metastasis, something that just looks histologically out of place. And again, being situated in the lower dermis is suspicious for metastasis. And going up to higher power, you can see that the individual tumor islands are kind of multinodular and composed of nests of hyperchromatic cells with some areas of necrosis here centrally and quite significant nuclear pleomorphism. It's not difficult to find atypical cells amongst this proliferation. There's a little zone of surrounding fibrosis. Sometimes you may focally see pigment, and that can be a helpful clue to a diagnosis of metastatic melanoma. And let's just see if we can find any here. Here's maybe a little melanophage and maybe some faint pigment in the cytoplasm, but it's not abundant. There's maybe some suggestion of very faint pigmentation within the cytoplasm. So metastatic melanoma tends to retain positivity for S100. And depending on the clinical setting, sometimes these less well differentiated tumors can lose their typical labeling with other melanocytic markers. So melan A and HMB45 or other stains that are going to target pre-melanosomes may not stain as prominently, especially as the tumor loses its pigment. So if you're using one of those more specific markers, it may not label as well as the tumor becomes more dedifferentiated in a metastatic lesion. One important example to note of metastatic melanoma is epidermotropic metastatic melanoma, and that can simulate a second primary dermal melanoma or a primary lesion. The melanocytes, just as they do in development, can hone to the epidermis, and some metastatic lesions can have tumoral involvement of the overlying epidermis. So a primary dermal tumor that's abutting the epidermis or a tumor that has some epidermotropic nests can sometimes be difficult to separate out from a metastatic lesion. But again, typically your clinical history will be helpful in differentiating those two scenarios. Another important clinical scenario with metastatic melanoma is blue nevus-like metastasis, and that can resemble a blue nevus both histologically at low power, but at higher power, typically you will see mitotic figures and some pleomorphism that you would not see in a atypical, not atypical, but atypical blue nevus. So now just to review poorly differentiated tumors and a general workup and approach to metastatic lesions. This is an example from the University of Michigan slide box. And this is a tumor that again has no connection to the overlying epidermis and is prominently centered in the dermis. And you can see that there are these nests of somewhat epithelioid cells. Some of them are relatively pleomorphic. There's hyperchromasia. There's a suggestion of these little bands or fibrous strands between some of the nests, areas of necrosis, and maybe some suggestion of glandular differentiation. So again, history here would be very important, but presuming that we had no history, a good background stain panel for a poorly differentiated tumor would be to start off with an S100 or some sort of melanocytic marker, an LCA or some sort of lymphocytic marker, which I don't think I would get in this case, but maybe if it were more of a small cell tumor, CD45 is the other name for LCA. Cytokeratin, so in this case, a CK7 and a CK20. If you were worried about maybe a metastatic adnexal tumor, primary adnexal carcinoma, you could add a P63 to that list, an EMA or CEA for carcinomas, and then maybe a Vimentin for sarcoma. And perhaps not in this case, I wouldn't maybe get the Vimentin or the LCA. But S100 is going to be your most sensitive melanocytic marker, which tends not to be lost even in desmoplastic melanoma. That would be a kind of a good panel to start with. And depending on what those markers showed, then you could go on with more specific immunohistochemistry. So in this case, our initial panel was positive for cytokeratin 7. So that would indicate a tumor above the diaphragm and showed some areas of glandular differentiation. So we checked they checked a TTF1. So this is an example of TTF1, and that's typically positive in lung cancer. And you can see it's a beautiful, nice, clean stain here with positive labeling. All right, moving on. This is another example of a metastatic lesion. So you may not know that this is metastatic immediately, but given the chapter, I think that's somewhat helpful. And then the other clue here is that there's no epidermal involvement. So from low power, we can see that this is an older patient with a good degree of solar damage, and there's a nodular collection of blue cells within the dermis. So as we go in a little higher here to view the architecture again, no intraepidermal involvement, and there's a good deal of space between the epidermis and the dermis. So whenever you don't see a dermal connection, your differential diagnosis would include a metastasis, but this could also be a primary dermal tumor. And then getting a little closer, looking at the architecture of the tumor, you can see it's composed of relatively monomorphic, small sheets of blue cells, which are comprising these sort of nodules of tumor. And there aren't really distinct features here. So we're not seeing really gland formation or ductular structures. When we go up a little higher, you can see that they're just these kind of, again, monotonous, kind of small blue cells. So this is a case where we would need immunohistochemistry. So small blue cell tumor, you could be thinking of lymphoma, melanoma, Merkel cell would be kind of the differential. So this is one where we would start with maybe a panel of markers. So some cytokeratins to see if this is epithelial, maybe a TTF1 to see if this is metastatic lung cancer, and perhaps a cytokeratin 20 to see if there was a perinuclear dot. But again, I'm going back to history, maybe just starting with a phone call to see, is there any history? So this was actually a patient who had a history of Merkel cell carcinoma. So in this case, we could do more of a limited panel. But if we didn't know that history, say this was a patient with no known history of cancer, you would start with maybe more of a broad panel. This is another area of the tumor, just showing the nuclear architecture a little better. The cells aren't overlapping quite so much here, so I think you can get a sense of the nuclei a little better. So here they're dark and a little more overlapping, but in these areas you can see a little better this salt and pepper chromatin pattern. So this was an example of a metastatic Merkel cell, and in this case you would see labeling with cytokeratins, but also a perinuclear dot pattern with cytokeratin 20. And then usually these will have positive labeling with synaptophysin and chromogranin. These will typically label with NSE, so neuron-specific enolase neurofilaments, and you won't see labeling with TTF1. So a lung cancer would label positive with TTF1 like we saw in our last case, and that would be negative in Merkel. On the topic of small blue cell tumors, if you are considering a B-cell lymphoma, important to note that patients who have been treated with rituximab, that their tumors may lose expression of CD20. So just kind of an important pitfall when we're talking about immunohistochemistry and workup of small blue cell tumors. And then lastly, I just wanted to share a helpful table with a summary of some of the markers that we've discussed today and a general approach when a tumor is a little more poorly differentiated. This is from a really helpful paper and a recent review by Jennifer Coe. And she is based at the Cleveland Clinic and is really an excellent dermatopathologist. And this is a review that she wrote with Gabriel Habernil, and this was published in Archives of Pathology and Laboratory Medicine back in 2019. And this is a review and diagnostic approach to tumors of unknown origin, cutaneous metastases from 2019. So this is a table that they published. And when you have a poorly differentiated tumor or a tumor of unknown primary, if you can find any foci of squamoid differentiation, so if you're seeing keratinization, a connection with an epithelial structure, maybe some sort of desmosomes or something connecting epithelial islands, you can start off with some cytokeratin. So like a pan-cytokeratin marker, a P63 can be helpful. Again, we discussed that. The other name is P40. So you can see P63 or P40 to see if it's primary adnexal origin. If it's skin origin, those will be positive. If it is a metastasis, then those are going to be negative. So you can try and see if it's a primary skin adnexal tumor, or if it may be a metastasis from elsewhere. Say if you have a lesion on the breast and you're trying to determine, is this maybe a syringeal neoplasm or an apocrine neoplasm from the breast tissue, or is this a metastatic breast tumor? A P63 could help you differentiate that. Same thing, maybe if you're on the face and you're looking, is this a primary salivary gland tumor, something from, a primary adnexal tumor from in the skin, or is it a metastatic salivary gland tumor coming up into the skin? P63 and P40 can be helpful in differentiating those. Your clinical is going to be helpful in differentiating. And then history, again, is helpful. And then CK7 and CK20, again, CK7 generally positive above the diaphragm, CK20 positive below the diaphragm. GATA3 we talked about in breast tumors, but there's some overlap here with breast cancer. So this table just kind of goes through a workup of helping you differentiate. And then the paper goes through more detail of differentiating those. Bladder, we don't see as much in the skin, but important in your differential. And then if you're seeing glandular differentiation, some more of the workup that you can do, CK15 is usually going to be positive in a primary skin tumor along with P63. So those two things tend to go together. Cytokeratin 15 you see in ductular epithelium, so like apocrine or secretory epithelium. D240 is also useful in working up primary skin adnexal tumors. So P63, P40, CK15, and D240 are a panel that kind of go all together for primary skin adnexal tumors. And then if those are negative, then you're looking at a metastasis. So that's where we use our panel of CK7 and CK20, and positivity and negativity would indicate more of a breast tumor. So if your CK7 is positive and your CK20 is negative, then you're going to be looking at something more above the diaphragm. So breast, lung, thyroid, and then obviously a few exceptions to that, but TTF1 would be more for lung, CDX2 more for GI tumors, ERPR, GATA3 for breast tumors. And this just goes through kind of a helpful differential with working out various adenocarcinomas. And then if the tumor is undifferentiated, your keratins are negative, then you can start going through more of a workup to exclude melanocytic tumors, um, workup for sarcomas, vascular differentiation, so SMA and ERG, and going through your differentiation for various lymphomas. So if you're S100 and SOX10 are positive, then melanoma, S100, again, usually not lost unless the tumor is very, very poorly differentiated. And then angiosarcoma, leukemia, sarcomas kind of follow down this S100 negative, SOX10 negative pathway. So this is a really helpful table for approaching a tumor of unknown primary in a patient who has no history of primary neoplasm elsewhere, and just kind of the general approach that we use when ordering immunohistochemistry. So right off the bat, you're not going to order every immunostain or the whole panel. So we start off with a very basic panel. If we can find any foci of a particular differentiation, you really try to limit your panel, and we'll order a bunch of unstained slides. And then as we get back bits and pieces, we'll order a little bit more. So you don't start off ordering every stain in this table. You try to very carefully hunt through the tumor and see if you can find, maybe is there some hemorrhage? That would be a clue to maybe some vascular differentiation, or if you can find some ductal lumina, glandular differentiation, or if you can find something that looks a little sebaceous, then you would kind of go maybe down one of the arms of this pathway without having to order everything. There are some cases where a tumor is very poorly differentiated and you can't find anything, and then you need to have maybe a little bit more of a shotgun approach, especially if the patient doesn't have a history of a primary. But again, we try to do a little more limited and then work down from there. Again, correlating with the physician and any other physical exam as much as we can, so we can limit ordering too many unnecessary immunostains. So I hope this table is helpful. I hope the lecture is helpful, and that you have a better grip on working up metastatic tumors. And if you have any questions, please feel free to share. We'll include some of these in our unknown session. So now that we've covered all of lever, we'll go through a few unknowns and board prep as we wrap up the year. So thanks so much and have a great day.